All right. Good morning, everyone. Welcome. It is my great honor to introduce to you the medical plenary for today. Dr. Catherine Creticos is the chief of the section of infectious diseases at Advocate Illinois Masonic Medical Center and has been in private practice for 33 years in the Chicagoland area. She is the medical director of clinical research at Howard Brown Health. She has been active in the treatment of patients with COVID-19 infection and is involved in research projects addressing the treatment and prevention of COVID-19 infection. Throughout her career, she has been devoted to research, clinical care, and education around HIV, AIDS, medicine, and infectious diseases. Now, this brief bio doesn't really give you the whole picture of the orthodox medical professional you are about to hear. In March 2020, when COVID hit, I called Kathy, eager for advice. What was I going to do with my practice? Could I see patients in person? Did I have to move to telehealth? All these questions were swimming through my mind, as I'm sure they were for many of you as well. She took the time with me to explain what experts knew so far about the virus, and I realized right then and there that as a physician, she had access to information and obviously the expertise to understand that information that we in the general public just couldn't and don't have. But perhaps more importantly, she also recognized from the get-go that we need our Lord and Savior Jesus Christ to get through this pandemic. She asked me if there was something OCamper could do to support healthcare professionals in the trenches. And so she was actually part of the inspiration for those daily quotes that OCamper sent out. I'm not sure if you realize that. So again, I am honored and eager to hear and introduce to you Dr. Catherine Creticos.
Thank you very much. And let's get this back up, hopefully. Let me just see if I have to do that one more time. Okay, there we go. Thank you so much, Randa. And actually, those quotations were incredibly useful to me and very supportive as the pandemic evolved. And I felt I really needed that type of emotional and spiritual support. So thank you so much. But welcome, everybody, and I'm very pleased to be here and proud to be following the many wonderful speakers that we've had over the last day and a half. As Randa mentioned, I'm an infectious disease specialist, and as in my position as chief of infectious disease and also at the hospital and director of infectious disease at the clinic, early on in the pandemic, I was called upon to make decisions regarding policy, treatment of patients. I was physically seeing patients in the hospital on a regular basis, and I still do, and in the clinic. So as a specialist, it was my job to help develop not only treatments, but decisions around policy. And I'm going to share with you some of the challenges that not just myself, but many people in the healthcare profession have faced, really focusing on the two main issues of the conference, unity and truth, and how has that impacted our ability as healthcare workers to provide care. So this is really my perspective. So let me start out, and I apologize if some of the slides are busy. You will get them to refer back to. So I'll use the slides really to highlight things. Let me tell you about the first patient that we lost to COVID-19 infection. Now, the first patient I physically saw was March 6th. And I walked into that patient's room. He was a 44-year-old man, no significant risk factors except for high blood pressure. And as he was gasping for breath, and I examined him, and then looked at his chest x-ray, which was a snowstorm. I walked out of that room and I said, I have never seen anything like this in my 33 years of infectious disease practice, and this is really going to change our world. So it was clear from the outset that we had something really different on our hands. But we were lucky. The first 3 weeks, we didn't have anybody who died. They all Eventually got better, was discharged, including my first patient. But on March 26th, a 22-year-old woman who had a kidney transplant, was on immunosuppressive therapy, was admitted. And we all knew her. The whole healthcare team knew her because she had actually been hospitalized for several weeks recently with influenza. And she was very ill with that, on a ventilator, something called ECMO, which is a machine where you actually take all the blood out of the body, circulate it through a machine to give oxygen, and then return it. So almost kind of like an external lung, okay? She made it through all of that, was discharged and was home. And then her boyfriend got sick. And she shows up with a 5-day history of cough, shortness of breath, and things went downhill very quickly after that. She deteriorated quickly. She came into the ICU. We could not keep her levels of oxygen adequate. And over the course of several hours, she had multiple cardiac arrests. And of course, the staff rushed in to resuscitate her. Multiple staff members were exposed to secretions. And we tested her for COVID with the PCR test, but now, you have to go back to March of 2020. Those PCR tests were not back right away. In fact, typically they would take 7 to 10 days, even in the ICU, to get a result back. So what do you do? And then the whole issue of what about allowing her family members, even just her mother, to come in and say goodbye. So there was a lot of division among the team, really sowed by all the uncertainty we were facing. We had limited diagnostic tools. Was this actually COVID? Was this something else? If it was a different infectious disease, we don't need to limit the mom from coming in. Because really, other infectious diseases, we know exactly how to manage those, right? There was no treatment for COVID. We're still struggling with good treatments, but there was nothing. And then we were really at a point where we had a lack of understanding, a full understanding of transmission risks, how to protect the team. And then not just the team, but if we had family members come in, how to protect other people in the hospital, other patients, anybody who might be exposed to them. So these were a variety of issues that we were struggling with. And healthcare providers want to provide the best care possible, but we are putting ourselves at risk when we take care of people with COVID. So what was the outcome? Well, indeed, the patient did pass, and the staff, when they went in for the arrests, did not take the time that we recognize now is necessary to put on the full protection. So the director of the ICU and 2 other physicians became sick with COVID. And the ICU director was very ill and was not able to return to work for over a month. And think about how that impacts the care of every other patient that comes into the ICU, because now one of our best doctors is taken out of the equation. Plus, there was a lot of conflict about whether to allow the mother to come in the room. We actually didn't have an official policy at that point, and I would have to say that even if there was an official policy, this was the first time we were turning to family members and saying, you can't come in. Now, that was almost unthinkable to us, right? How many unthinkable things have we done since the start of the pandemic, right? But the head nurse made the decision to allow the mom to come in and say goodbye to her daughter. So healthcare workers face personal challenges with COVID-19. We know that as of April, and now that number is higher, of course, that over 115,000 healthcare providers have died due to COVID-19 infection, and over 3,600 in the United States. And that's really from the estimates from exposure at work. Obviously, people have individual exposures too. But the healthcare worker has many other challenges beyond the personal risk. And really, I'm going to focus on the issues of unity and truth and how that has impacted our care. So what about unity? Well, there has been lack of unity at all levels, really. On the personal level, what do I, as a healthcare provider, do about masking, about social distancing, about indoor-outdoor activities, quarantine? And when I say that, it's as a healthcare provider, you're also a representative for your profession. And me, I'm a representative for infectious disease, right? So people look to me for advice and also a way of life almost in terms of how to conduct myself. So that impacts my choices. And you know, at a personal level, there is a lack of unity. You might think all infectious disease doctors think the same thing, but that's not true. Of course, you get 10 in the room, and they all have 10 different opinions. So there's definitely a lack of unity regarding that. I also work with an infectious disease group that has over 100 members, and we're in 8 different states, and we have a weekly meeting about COVID-19. And we take polls about our decisions around masking, PPE, vaccination of children, and we're not 100% on anything. So just want to put it out there that not all ID doctors are going to have the same opinion, and that lack of unity can be, you know, it's healthy. It's healthy to have a discussion, but it can also lead to issues around decision making. At the professional level, of course, there's decisions that have to be made within the hospital system or the clinic about masking, social distancing, visitor and trainee restrictions. What about all the people we've been training, nurse practitioners, student doctors, all these people who experience the medical profession through a training program, all of that had to shift, and decisions around that. And then finally, making decisions about treatment and management. That there was a tremendous amount of lack of unity at that period of time. And then, of course, at the political level, and we all have experienced that. In the beginning, the CDC said, no masks. Masks don't work unless you're using the highest level. Masks won't work because people can't put them on right. They touch their face too much. But as we had more information come through about, you know, masking, that changed. So we had really a lack of unity around masking. And of course, we had different information coming from WHO, CDC, other parts of the world. And I think we have to recognize that there were, you know, quarantine and travel restrictions, mandates, CDC guidelines, experimental use authorizations that were sometimes conflicting. Let's see here. I think I go to this one. Did I? There we go. No, I think I skipped over this one. No? Thank you. Okay. So I put this slide up here really to also take us back to the beginning and take us through this whole pandemic year. And our division has been driven by the evolving pandemic and the world in upheaval. And we've all experienced that. Of course, the very beginning, brand new virus out of Wuhan, mysterious, very little information initially. And then from Wuhan, we started to see those terrible photos of people dying in the corridors, people not able to access oxygen, moved to Europe. We had Italy, Spain, same thing, people dying in the corridors, not having access to the intensive care units. This vision, but it's not going to come to the United States. We're going to shut down our flights from China, and we're not going to let the cruise ships land, and we're going to be fine, right? So, of course, that didn't happen. And We see New York overwhelmed. We see other parts of the states overwhelmed, and the same picture of not enough ICU beds, not enough people being able to access care. And then the other big thing that hit healthcare workers, we had no PPE, personal protective equipment. So for the first month of COVID until the end of April in my hospital, we were actually told not to wear masks unless we were physically going into a room of somebody with COVID. I actually had to go up to physician, nurses, medical assistants who had a mask. They had bought one at Costco or whatever, and they had a mask, and I had to tell them they could not wear it because hospital policy said, you know, if everybody doesn't have enough masks, then nobody has enough masks, right? So that was the policy, and believe me, that provided a tremendous amount of division among all healthcare providers at the facility. But that was what we were dealing with. Finally, we had enough personal protection equipment, and then the other thing that happened, the world shut down. So when I say it was the first time we had to restrict a family member from being at a deathbed, think of all the other things we did for the first time. I mean, we canceled all the sporting events. We canceled everything. The world shut down, right? Could you ever imagine our churches closing, right? It's unimaginable, right? So that's what happened there. And we did see a benefit with the flattening of the curve so that our ICUs were not overwhelmed. I think other members of the conference have really spoken beautifully to the uptick in the mental health issues that we saw very quickly take on as people were unemployed, isolated, had personal loss, and were under tremendous other stresses. And then new hope. Vaccines are starting to be developed. Some information about treatments. Now we're hit by another strain of the virus that caused a huge increase in cases over the winter. That's the Alpha strain. Finally, vaccines start, numbers go down, and now we have to deal with the Delta variant and the impact on people who are unvaccinated. So chaos from start to finish, right? And really the lack of unity also driven by the novelty of the disease. So all aspects of this was something we didn't know. We didn't know how to describe the manifestations of the disease. And even today, with the Delta variant, we see different manifestations. And they're different even in people who've been vaccinated, who get infected. So it continually is evolving, and we have to redescribe what we're dealing with. Understanding morbidity and mortality of this disease, how it's transmitted, how long you can transmit the virus, how to best diagnose it, what are the treatments, and then the long-term effects of being infected, right? Having had the infection. 10 years from now, we're going to see people coming down with Parkinson's disease or something from the neurologic involvement? Or are we going to see long-term brain fog or other types of complications? Where did it come from? Another area of tremendous debate, right? And then finally, other future risks, including clearly a lot of concern about future risks from the vaccinations as well. So I've talked a lot about the lack of unity, but I also want to look at the things we are unified about in the era of COVID. And we're unified in our desire to care for each other. Our healthcare workers, clergy, essential workers, governmental leaders, all types of other researchers have been working tirelessly through this pandemic. And, you know, when people say the vaccines were developed quickly, I like to remind them that the researchers, the lab techs, the participants, all of these people worked around the clock to get this done in record time. This was not just some accident that it was accomplished quickly. The governmental bodies reviewed the data immediately. So a lot of things went into it. And I don't want to digress too much, but you know, I just want to focus on the fact that we have had unity as well during this pandemic. And we've been unified in our faith approach to COVID. Our hierarchs of the major faiths throughout the world have been united in their messages about support for one another, love for one another, and the importance of really taking care of each other in many different ways. And in our desire and our focus to understand this new disease. And I'm going to talk a little bit about some of the proliferation of data in the next few slides, so I'll skip that right now. So I'm going to kind of refocus the talk now on the other aspect of the other main topic of the conference, and that's truth. Truth in the time of COVID, looking for the truth. And indeed, that has been another area of great challenge for healthcare workers. So the initial information came out of Wuhan, China about this virus. And just from the start, we've had issues around truth, right? The information has continued to be fragmented, unverified, and probably censored. But that's the best we have. That's what we have out of looking at the origin of this virus. And then really, especially at the onset, no concrete information for specialists. I really felt like I was on my own many times. You know, Randa would call me, other people would call me for advice, what do I do? And honestly, you can only give the information you have at that time, with the great caveat that we don't know a lot. And in fact, we still don't know a lot. We know more. We know more. And in fact, really, I would spend at least 2 hours every morning combing through every article, every news article, every scientific presentation that I could find, really to be as up to date as possible, to be a resource for people who needed it. And I think the other challenge in terms of the truth component is that I, as an ID specialist, or my colleagues, would know from our training and our experience what's the right thing, or at least what we felt the truth is, but then the policies were different. And I give as an example the one about masking. You know, I personally was recommending to, I shouldn't say this, but to the people who had the mask, stick them in your pocket. When you go see the patient, put it on and then put it back in your pocket, because it makes no sense if you've got a mask not to wear it. But, you know, it was a challenge to deal with the conflicting decision-making from the expert versus the hospital policy versus the CDC versus the WHO. And then we would have preliminary data that would lead to a certain type of recommendation, but we would have to rescind that when the data was recognized not to be accurate or incomplete. So, for example, the tests that we were using, not all of them were very good, so some had to be taken off the market. The whole issue around masking and our back and forth on that. And I'm not sure you remember, but hydroxychloroquine was a drug that is an old drug, repurposed for this pandemic, and it was authorized for use. So there was preliminary data that there was some benefit, and we used it in the hospital with what we call experimental use authorization for about a month and a half. And then that was rescinded when additional studies showed that it was not beneficial. So, you know, back and forth, right? And a lot of concern about what really is the truth here. What do we know? So, you know, I've mentioned a lot about the issue with regards to ID specialists, public health, looking at developing policies. And really, there was a constant conflict, and there still is, looking at public health safety, what the science tells us about that, but also looking at the economic impact and the issue of individual rights which we value in this country, and how those two interact. So that policies are not always pure science-based. They take in these other components as well. I mentioned, again, changing recommendations, but as a specialist, I would have to check the CDC recommendations in the morning and in the afternoon, because they might change. So there was so much of that going on, which really, I think, fed into this concern about what do we really know is the truth. And then same thing within the hospital versus the clinic. There are actually different policies, so you have to be up to date on both. When we talk about the CDC as a source for information to help guide decision making, I'm not sure everybody recognizes that the CDC has become it's a tremendous source, but there is so much data there. It can be overwhelming to try to search for it. So, for example, as of today, on the CDC website, you can access 112 printable documents in multiple different languages, 270 videos about COVID-19, and thousands of pages of information and other policies and aspects. Again, continuing to be updated. And I did put the CDC website. Actually, it's good for all types of people to access it. There's information for not just specialists, but lay people as well. So that's something that might be a good resource for you. But again, the caveat of the fact that this does change. So looking at scientific data challenges, I mentioned before that we are all united in our efforts to really understand this virus and to gain more information and knowledge. But looking for truth through these scientific publications and research projects is a tremendous challenge. So as of now, there have been over 125,000 COVID-19 related scientific articles. Actually, that was just within the first 10 months of the pandemic. And compare that to being a little over 3,000 articles in the first 10 months after H1N1, the bird flu, came on board. So just this huge explosion of scientific information. There are a couple of other things that have made it challenging to really know the truth when it comes to these scientific articles. One is something called open access. It's a wonderful idea, and I think it's a tremendous idea, very supportive of it. But what that means is that these articles, these papers, data are published without people having to pay for a subscription to the Lancet or to belong to the University of Chicago website or something like that. So without payment, you have access to these articles and this information. It's a great idea, but it removes an element of control about what is being put out there. So in other words, there's not the review of the information to assess how well the study was conducted, how verifiable the data is, and whether or not the authors are biased. Okay, so all those different aspects are removed. And then pre-publication has been allowed as well. So again, before peer review, the process of trying to determine how good the data is and how well the study was conducted has been removed. So that's an element of making it more difficult, more challenging to discern the truth, right? And I think that providers who are not as experienced in reviewing data may just, fast forward to the very end, the conclusion, and not look at everything that has brought out that information, right? So it's important that we look at data and understand, is it good data? Is it stuff that, we can trust? Is it really true? And that's why we always look for additional studies to verify. But with so many different studies coming out, that has been a real challenge. And then some articles have actually been recanted. An example of how this can be so challenging. At my hospital, there is a second infectious disease group. And around November, December, one of the drugs that has come into use for people who had very advanced COVID had something called cytokine storm, where their immune system is in hyperdrive and causing this patient to have the inability to oxygenate because the cytokine proteins have invaded the lungs. Okay, trying to shut that down, there's a drug called tocilizumab. Tocilizumab is a very profound suppressor of the immune system. Our group, had been using tocilizumab with good results and had published actually our results about the benefit. But there was a large trial from WHO that had showed that it was of questionable use. But when you looked at the data was not well, the way the data had been, the way the study had been conducted was not well conducted. And so the other team had repeatedly said the use of this drug was a terrible idea, and the other infectious disease team was doing everything wrong, and our group was saying, we have good data to support it. So you can see that it led to a real question for the doctors on the healthcare team, what's the truth here? Which infectious disease team is really right here? And I'm just bringing it up as an example of how challenging it can be, even on an individual situation of how do you manage a patient? How do you manage this patient today? Is this drug something I'm going to use or not? So the challenges are more complicated. So remember, these studies are conducted at different periods of time during the pandemic, and they're conducted in different populations with different endpoints and different study designs. So you can't always compare apples and oranges, and that really leads to sometimes different conclusions that can further obfuscate the truth. And if the study was done early last year, maybe with the original strain, versus late last year where we had the alpha strain, versus sometime this year where we had the Delta strain, you're dealing with a different animal to some extent. This Delta virus is 5 times more contagious, and it also has a different series of manifestations. Remember that the research team has to be protected too. And how do you conduct research in the setting of a pandemic? Where do you see these patients? How do you protect your staff? There's not enough PPE for the ICUs in the hospital, so how are you going to have enough PPE for the research team? And then finally, the same people who are doing all the care for patients are the ones who are trying to vaccinate patients, test patients, counsel patients, and now do research on patients. So there's just not enough people to go around, and there's a lot of pivoting for that to occur. And then finally, as I mentioned before, in terms of what is the truth that we're looking for, there is differences in terms of approach between ID specialists within my own group, between ID groups, and then certainly within the healthcare team. So on the team, we have pulmonologists, we have ICU experts, we have the primary care team, we have the behavioral health people, we have the social workers, and they all have their input, and their understanding of this disease. And this is not just something that's focused in the United States. Here I put up the different research trials that are throughout the world. And you can see that there's just thousands of research trials ongoing right now, but hundreds in Africa. And, we have trials throughout the world. So people are really continuing to look for truth and trying to understand this on a world perspective. So I'm going to take a few minutes now to look at the concept of truth during the pandemic through social media, sort of the elephant in the room, right? Because really, when we talk about looking for truth, I think social media is the other component here. And if I recently, before this conference, I Googled COVID-19. And there were 8 billion hits that came up, right? So when we talk about the vast amount of information, et cetera, on social media, it's overwhelming. And we do know that misinformation, the misinformation phenomenon during the management of disease outbreaks is real, and it's actually now been coined infodemic. So infodemic basically looks at this whole misinformation phenomenon that has further sped up the epidemic by influencing and fragmenting social response. And indeed, we know that amplification of information, both reliable and unreliable sources, occurs on social media. And there is actually a fair amount of research that has shown the dynamics is also impacted by the platform. So this is a really busy slide. I know you can't read it, but it's a study that was done early. It is a retrospective study looking at social media posts during the first 6 weeks of the pandemic. So it actually goes all the way back to like January, February of 2020. And they look at the different social media posts. And amplification of information that was both credible and unreliable occurred across all the platforms. And the platforms they studied were Gab, Reddit, YouTube, Instagram, and Twitter. But they found that the more unregulated platforms, in particular Gab, were most likely to amplify unreliably sourced information. So we do see we see amplification of this material all across the board, but more of the unreliable or unsourced information from the less from the platforms that are less able to manage the information. And WHO has actually put out a statement about the social media impact. And what they have to say is that this pandemic has demonstrated that the spread of misinformation amplified on social media and other digital platforms is proving to be as much of a threat to global public health as the virus itself. We know technology is helpful for many reasons in terms of creating opportunities to keep people safe, informed, and connected to different treatments and advice, et cetera. However, we also know that this infodemic has continued to undermine the global response, jeopardizing the control of the pandemic. So WHO fairly recently conducted a study that really tried to assess social media engagement in the younger group, the 18 to 40-year-old group. And that encompasses what we call Generation Z and the millennials, okay? And they looked at over 23,000 respondents in 24 different countries on 5 continents. So this was definitely a global approach to understand social media impact. And a few interesting things. These Generation Z and millennials, when they were asked what information they would be most likely to post on social media, actually almost half, about 44%, both male and female, reported that they would likely to share scientific content. And we always think that this generation is going to post, cat pictures and, all these little funny quips and stuff like that, and emotional content. But actually, when asked, they were a little more focused on the scientific content. And the other thing I found interesting is that it wasn't just videos and images. And we think of this, and I don't mean to offend the folks of you in this age group. I know there are plenty of you. But, we see so many times that on social media, these types of things get posted, the cute pictures and stuff like that. But actually, articles were more likely than videos or images. So I think that that's information that's fairly interesting. And in fact, more than half of almost 60% of Generation Z and millennials in this survey are very aware of fake news and feel that they can spot it. However, unfortunately, a good third or more just ignore it. They don't take the effort to try to either challenge it or to counter it in some way. Let's look at Americans and social media. This is a study looking specifically at COVID-19 vaccine news on social media, and about half of U.S. adults when asked about getting information about COVID-19 said that they had that information from social media. And, the headline says most don't see social media as an important way of keeping up with the news on the vaccines, but actually almost 40% did think it was an important way. So I'm not sure I agree with that, the headline there. But clearly, we are turning to social media for information as opposed to, for example, CDC website or our physician or some other, our newspaper, looking more for social media. So, in fact, we understand that there's both misinformation and disinformation. There is a distinction. Misinformation is false information shared by people who do not intend to mislead others. But then disinformation is false information deliberately created and disseminated with malicious intent. And we have both. Clearly, we have both. And both have caused significant and real harm. When we think about types of false information, there's mischaracterization of the disease or protective measures. There's false treatments or medical interventions, scapegoatings of groups of people, and then the conspiracy theories about the pathogen, politics, profiteering, etc. And there is an impact from this disinformation. There was a nice UK study that was done and looked at 5 different countries, including the United States, and they found that public misbelief and misinformation about COVID-19 is actually not common. However, a substantial proportion of people view the misinformation as highly reliable in each society. So it wasn't just the United States, but in each society. And then a small group in each country find common factual information highly unreliable. So we have people who actually think the facts are not unreliable. And then the higher the belief in misinformation, the lower the compliance with public health guidelines and vaccine acceptance. In all countries, the higher trust in science and higher numeracy skills associated with lower susceptibility to misinformation. This is a bit of a busy slide. I'm only going to focus on, addressing information. Actually, the CDC has given some guidance about this, and I think they start at a very good place. Listen to and analyze misinformation, but listen. That's important. We need to listen to each other. Engage and listen to your community. Do your best to share accurate, clear, and easy to find information. And use trusted messengers, people that maybe the community recognizes as trusted. I'm not going to go into the other information. You can look at it at your leisure. And this, too, is a pretty busy slide, so I'm just going to focus on a few things here. If you see false information online, don't repeat or retweet it. Retweet it. And try your best to provide true information. Engage respectfully with people if you need to discuss this. Discuss alternative explanations, encourage verification. And then there are ways to actually help you as a healthcare provider check for false information. So look at the source credibility. Verify the information from other news sources, trusted people. Think twice about messages designed to appeal to emotions. And, there are a variety of ways to really try to respond to false information. Just trying to check my time here. So just to lighten it up a bit, I found these comics were circulated about from my ID colleagues, but I think they really speak to what a lot of healthcare workers feel. Yes, politicians, they have a lot to say about COVID-19, but, would you want them doing your colonoscopy, right? And, if you're ill, who are you going to look for advice and treatment? I'm not so sure the comment section is the best place. So, and then good old Homer. We all love Homer. But I think this is a great quote because it really highlights the fact that facts are important. You can use them to prove anything that's even remotely true, right? But the problem, of course, is that a lot of things that are not true have some factual component to them. So what's a good example? I was speaking with somebody at the conference yesterday, and there's a terminology that's used when describing the vaccine that talks about an aspect of it that causes luminescence or some lighting of the element for identification. And the terminology has Lucifer or something that sounds like Lucifer in it. So people have, well, okay, there's that truth, but that's not what the terminology is referring to. It's not referring to Lucifer the devil. It's referring to a medical term that is used for luminescence or light. So yes, there's this little fact, but you've got to use the fact the right way, right? So anyway, how does this impact all of, the lack of unity, the search for truth? How does that impact our care? Well, clearly, this has impacted vaccine hesitancy. For me, my ICU patients and the patients that are dying now overwhelmingly are unvaccinated. And that I can attest to because those are the patients I've been seeing. And clearly, statistically, that's what we're dealing with. And unfortunately, the other few people who are in our ICUs who have been vaccinated are people who are not going to mount an immune response because they can't. Their underlying immune systems are not adequate to mount a good immune response. And so I think that that's something that is a reality with the vaccine hesitancy. And of course, delay of care for appropriate treatment, the ivermectin story. Ivermectin is a wonderful drug. I don't know if you realize, but it won the Nobel Prize for being a tremendous advancement for the treatment of parasitic infections in human beings. I've used ivermectin many times. I think it's a great drug. However, the data for COVID-19 is still accruing. It's still evolving. There's some data that support it. There's some data that does not. But when patients go out and access ivermectin on their own and take perhaps the wrong dose, to me, the biggest harm is that they delay coming in for what they actually need, which would be, for the high-risk patient, a monoclonal antibody treatment. We have them, they work, they're not getting them. So again, there is an impact on care. And then certainly there's shortages of equipment and medications with the need for rationing. You might not think that's happening, but it is. And why? Because we are still seeing surges in parts of the country with those areas becoming overwhelmed. I mentioned tocilizumab, it's now rationed. We do not have enough, okay? New Zealand can't even get it. They've actually stopped shipping it to New Zealand because they don't have enough patients over there. So yes, there is rationing. It's gonna happen. And then, of course, there's the whole issue around vaccination requirements and the need that healthcare workers have to be vaccinated, first responders, and a labor shortage. I want to take a minute to talk about compassion fatigue. This is something which has been coined for healthcare workers who are taking care of people who are not vaccinated and get ill with COVID. And, you know, in Florida, doctors staged a workout to protest the fact that unvaccinated patients are coming in ill. An Alabama physician actually refused to care for unvaccinated patients, stating, I cannot continue to watch my patients suffer and die from an eminently preventable disease. And then we mentioned about rationing. What I put at the bottom is a link to an opinion piece from a physician in LA that honestly, if you want a doctor's firsthand experience about dealing with patients who are sick that have not been vaccinated, this is a very, very moving and well done piece. But how do we go forward? We still must go forward. And with all of this division and lack of truth, how can we find a way forward together as healthcare workers? Our faith leads the way. Love one another. And you've heard this from other speakers throughout the conference. And this is something that our hierarchs have emphasized in their statements as well, that we need to care for one another, show our love for one another, and that, you know, this is our faith tradition. Faith traditions are important and can be reconciled with good science. The same God who sets the truth for us and who we are also has set the same order and principles for how the world and science is established. There is an underlying consistency in the world of faith and science. And in this way, we can move forward together. Our Hippocratic oath really focuses on the commitment to do our best and limit harm. And I put the little quote here, I will lose those dietary regimens, which will benefit my patients according to my greatest ability and judgment, and I will do no harm or injustice to them. This is actually a news clipping from 1928 about the flu pandemic. And look how similar we've got today. Wear a mask, wash your hands, live in abundance of fresh air day and night. Early symptoms, report to the doctor, respect the quarantine regulations, avoid crowds, do not neglect your mask, do not disregard the advice of a specialist just because you do not understand, do not disregard the rights of the community, obey cheerfully the rules issued by authorities, do not think you are entitled to special privileges, do not go near other people if you have a cold or fever. You may expose them to influenza and death. Our faith guides us as well. Compassion and understanding for those affected. The parable of the Good Samaritan. Do not judge. The parable of the woman caught in adultery, and also the teachings from the Sermon on the Mount. Trust in the Lord. And here I've put several several quotations from the Old Testament and New Testament. But, they all point to trust in the Lord in your work. I'll just read the last one. Trust in the Lord with all your heart, and do not lean on your own understanding. In all your ways, acknowledge him, and he will make straight your paths. Be brave and hopeful. And, again, I've put some quotations here. I can do all things through Christ who strengthens me. Be strong and of good courage. Do not fear, nor be afraid for them, for the Lord your God, not be afraid of them. For the Lord your God, he is the one who goes with you. He will not leave you nor forsake you. I don't have time to read every single one, but I wanted to end with this slide here. Support one another. And again, bear one another's burdens, and so fulfill the law of Christ. Let nothing be done through selfish ambition or conceit, but in lowliness of mind, let each esteem others better than himself. Let each of you look not only for your own interests, but also for the interests of others. So continue encouraging each other and building each other up, just as like you are doing already. And be kind to one another, tender-hearted, forgiving one another, even as God in Christ forgave you. Be kind. Thank you very much.
Thank you, Kathy. That was amazing.
If you want to take questions or comments,
yeah.
It's late.
All right, so it's 9:59, but I would say if someone had a burning question that would be helpful for all of us, let's take one question and then we'll move on. Who's going to be the lucky one? He jumped. Father Isaac jumped up first. He
wins. Thank you for a very edifying talk this morning. It just occurred to me as you were speaking the kind of analogs between the chaos of information that you're describing and the first centuries of the Christian church, when there were various things being spoken, not all of which were completely false, but many of which were not the whole picture. And it just, the Council of Nicaea has been criticized at times because it had a political component to it. But truth is political along with other things, and truth is social, and truth is psychological. So I just hear in this, when I think about the chaos and kind of pandemonium you're describing, that it's an invitation to wisdom and an invitation to understanding truth in a holistic way. That if we come to lack credibility and people are not seen as being able to credibly speak the truth, we're really in disarray. And so I'm so grateful for your talk this morning, and I hope that we find ways to, establish our own believable canons of truth in society. Again, thank you.
Thank you. Thank you. All right. We'll be around, right?
Yes,
and
yes.
Now you all know her. Don't mistake her for her twin sister. All right, so it's 10:01. We are trying to keep things on schedule. We have a half-hour break, and at 10:30, we will dive back into workshops. While you are in the hall having your coffee break, remember to visit all the exhibits. Also, the books from past conferences are on sale at the registration desk. So if you have missed past Camper conferences, the publication of those proceedings are there, and you are welcome to look those over. All right. Thank you.